A 28-year-old female is brought to the emergency department minutes after receiving an IV antibiotic at a local clinic. She is anxious, restless, scratching her skin, and complaining that her throat feels tight. On examination, she has generalized urticaria, facial swelling, audible wheeze, tachypnea, and severe respiratory distress. Her vitals show a BP of 74/42, heart rate is 142, respiratory rate is 34, and oxygen saturation is 86% on room air. This is anaphylaxis, a rapidly progressive, life-threatening systemic hypersensitivity reaction caused by massive mast cells and basophil degranulation, leading to release of histamine, leukotrienes, prostaglandins, and other inflammatory mediators. The result is profound vasodilation, capillary leak, bronchoconstriction, and airway edema occurring simultaneously, essentially producing distributive shock with respiratory compromise. Anaphylaxis is a clinical diagnosis, and treatment should never be delayed for lab confirmation. The diagnosis is made when there is an acute onset illness involving skin or mucosal symptoms along with respiratory compromise or hypotension, or involvement of two or more organ systems after exposure to a likely allergen. Common triggers include antibiotics, NSAIDs, insect stings, foods, contrast agent, and sometimes no trigger is identified at all. Immediate management begins with airway, breathing, and circulation assessment, but the single most important treatment is intramuscular adrenaline. Adrenaline should be given immediately into the lateral thigh at a dose of 0.5 mg IM in adults using 1 to 1000 concentration and repeated every 5 to 15 minutes if symptoms persist. Oxygen should be administered aggressively, 2 large bore IV cannulas inserted, and rapid fluid resuscitation started because these patients can lose a significant portion of intravascular volume into the extravascular space due to capillary leak. Nebulized salbutamol may help persistent bronchospasm, while antihistamines and steroids are only adjuncts and must never delay adrenaline administration. If airway edema progresses with stridor, voice changes, or impending airway collapse, early airway intervention is critical because delayed intubation can become impossible. Patient must also be monitored for biphasic reactions where symptoms recur hours later despite initial improvement. The key learning point is simple. In anaphylaxis, adrenaline saves lives. Delay kills.